We are all here together to talk about the recent advances in adenocarcinoma of the esophagus and stomach region. I'm really excited to be here to discuss this data. I'm a medical oncologist in New York at Memorial Sloan Kettering Cancer Center. And today I'm joined by my colleagues and drug development and also biomarker development in this disease. Today we have Dr. Klempner, who practices in Boston. He leads the gastric and esophageal program at Mass General Hospital. You've seen him at many podium presentations and meetings. He knows a lot about this disease and has a great way to explain the biology because he has, both worked in the lab. He started at Luke Kentley's lab and then also is doing a lot of translational work and drug development that is supported by many important internal and external funding mechanisms. Dr. Smith, Lizzie Smith, is a oncologist in Cambridge, UK. She has really been important and instrumental in the biomarker development in Europe for this disease, has done a lot of important work looking at HER2 and other PD-1 related targeted therapies. We actually worked together for a few years while she was in training at Memorial Sloan Kettering. So it's really a pleasure to be able to see Dr. Smith really blossom into the investigator, an established investigator that she has become. So without further ado, let's start our program. So I will start with gastroesophageal cancer and particularly biomarker development in stage 4 disease. We know this disease is quite complex, at least in the United States and Europe. The chromosomal instability is a big problem, and most of our patients present with advanced disease where the cancer is metastatic. There are several different subsets that are immunotherapy sensitive, such as EBV, Epstein-Barr virus, and MSI-H tumors. Those are rare, so the most patients that you and I see in the clinic have P53 mutations and many co-occurring alterations, many of which are not targetable, the low TMB burden, tumor mutational burden. These tumors are also tend to have co-occurring amplification. So HER2 is one, but in the context with other alterations, the targets have not lent themselves to one disease, one drug approach. So chemotherapy has been very important. So what we think about biomarker development in the clinic, so routinely now, we should be testing for HER2, usually starts with immunohistochemistry and also by NGS for amplification. Later on, MMR by IHC, and again, this is a rare subtype, but important subtype, even in early stage disease. EBV, we do routinely test at Memorial Sloan Kettering. I think now that immunotherapy is readily available in first-line setting, it's not as important, but it's still useful to know the EBV status. And then combined positivity score by PD-L1 is used routinely. Coming into clinic eminently is Claudin 18.2 immunohistochemistry. I think that's the number one question everyone asks. Should we test for Claudin in the clinic? Not yet, because we don't have a really FDA-approved antibody, but it's coming very soon. And then next is probably FGFR2 overexpression. So it's about a third of each population. And then although we do routinely perform tumor sequencing, it mostly informed plasma ctDNA analysis. I think, in our tumor types, as I mentioned, although we do have these one-off rare amplifications that are targetable, the duration of response so far hasn't been kind of disappointing. So where we are with HER2 is that it's an important biomarker. It's the first biomarker that was established, and it was established 12 years ago, over a decade ago, based on the trastuzumab chemotherapy combination and the TOGA study. We know the TOGA study results in about 13.8 months median overall survival and overall response rate of 47%. So since then, we haven't been able to move the needle forward until recently, because although up to a third of adenocarcinomas overexpress HER2, the rate is a little higher in the proximal and G junction tumors, and it's probably closer to 15-20% in a distal gastric cancer. In our cancer, unlike breast cancer, it co-occurs with other alterations. So RAS, PI3 kinase, MEK, other bad things, MAP kinase activating alterations that just doesn't lend itself to targeting. And as a result, dual HER2 inhibition with pretty good drugs such as lapatinib, pertuzumab, and other ADCs like TDM1, for example, have failed in gastric where it was successful in breast, because HER2 in itself rarely occurs by itself. So when we went around the HER2 axis and targeted it with dual PD-1 HER2 blockade, we got some promising data. We'll see if, the survival data pans out, but that's kind of pembrolizumab, trastuzumab chemotherapy was the first FDA-approved indication in first-line setting for HER2-positive disease since TOGA 12 years ago. And in second line and beyond, we now have T-DXd, which is trastuzumab deruxtecan. It's an ADC that has much more firing power comparing to T-DM1 with higher drug-to-antibody ratio and irinotecan-like chemotherapy moiety. So that worked in second and third. So that's where we are with HER2. So let's dive into a little bit more in terms of the biomarker co-occurring alterations. What we did in 2018, we published this data where we looked at first-line setting and looked at trastuzumab-based, chemotherapy regimen patients who are getting it in first-line setting, and just, doing simple next-generation sequencing in the clinic helped us understand that if you have co-occurring alterations, if you have low level of HER2 overexpression and have higher level of HER2 amplification, those things can be predictive. So, if you have let's say intermediate quartile amplification by HER2, and then the patient has MYC and EGFR, those patients won't do as well in terms of durability of response. And so those are the patients we need to think about how we could target better. What we also know is that over time, as you're on trastuzumab-based therapy, PD-L1 overexpression goes up. And PD-L1 overexpression, because Traz really works through ADCC and gastric, most likely, we have, important hypothesis that perhaps dual anti-PD-1, anti-HER2 blockade will pan out. And this was phase 2 data we published in Lancet On. A couple of years later, a Korean group published a very similar data set, also in their small investigator-initiated study. So it's nice to have East and West sort of concordant results. We had a 91% overall response rate. Median OS was 27 months. And what we saw is really durable, almost vaccinal-like responses, which was great to see for HER2-positive disease. So we took it pretty quickly to phase 3. And the phase 3 data so far is promising, showing a delta increase in overall response rate in 23%. So again, as I mentioned, you expect TOGA regimen to be 47, 50%. So the comparator arm did very well here in Keynote 811 data, compared to 74% in the experimental arm. The depth of response, the shape of the waterfall plot with addition of pembrolizumab was all heading in the right direction. Now we're awaiting the survival updates. So based on this interim analysis, the FDA approved pembrolizumab in the first-line setting, and it's great to be able to maximize the options and maximize survival and response in first-line setting, because guess what? Not all of our patients will get to second line. So in the second line, acquired resistance to trastuzumab is just tumors get more complicated. They lose HER2, they gain more EGFR and RAS and other things. So the longer you wait, the less of sort of satisfying responses you will see. So to be able to see T-DXd, trastuzumab deruxtecan responses when T-DM1 failed, it was a nice option for our acquired resistance patients in second line. And why do we think not all ADCs are created equal? Was because with trastuzumab deruxtecan versus T-DM1, you do see a little bit more, at least preclinically, bystander effect. So we talked about heterogeneity. We talked about that, we have subset of patients with focal amplification and, just in 10% of cells that even on NGS wouldn't be enough to call amplification. And then those patients probably are the ones that need T-DXd or the bystander effect of the ADC, a robust ADC, the most. And, it's critical to understand that for any strategy going forward in second, third line, even in first line, the heterogeneity in esophageal gastric is a rate limiting step. So this is the Destiny Gastric 01 and 02 studies. I'm sure you're familiar with it, but just so you understand the difference between these studies. So 01 was the first study, as the number suggests, and it was a randomized study against investigator choice chemotherapy. So it was mostly Japanese and Taiwanese study. There were non-US patients. And as you can see, even in later lines of therapy, median OS is 12.5 months. That's jaw-dropping, impressive data, likely because of patient selection, right? If you live long enough, you likely, and you are HER2 positive, you likely do better, especially, with this regimen. The response here, was 38%, which is very, very nice and better than standard chemotherapy. And so the FDA approved the T-DXd regimen, even just based on this data. And then Destiny Gastric 02 came out, which was a confirmatory study in the US. It's actually just in the process of final publication. And so you will see the data finally, but essentially it was very similar response and similar progression-free survival. And you could say, well, I don't understand, it's a second-line study. Why did it show the same data as a third and beyond study? Well, it's likely because in our US population, we have more G-junction tumors. So like I said, they're more complicated with more co-occurring alteration, more chromosomal instability. And also it's probably the same population in second line or third lines that will benefit from this drug. So from you strategically, you need to just pick when will the patient be most likely to get it. In my clinic, it's usually in second line, especially if the tumor is still HER2 positive after trastuzumab progression, because those patients are more robust. Trastuzumab deruxtecan is chemotherapy. It's not, sort of a walk in the park in terms of side effect profile. And it's a higher dose, 6.4 mg per kg with gastric patients. So that's why I think in second line, you're more likely to get it and, successfully, and it does work. So let's now review immunotherapy options, right? So we talked about HER2. It's the first validated biomarker. For all else, for majority of our patients, there's no biomarker right now. Claudin is coming. But right now in first line therapy, immunotherapy has been really what, led to a lot of FDA approvals, these positive immunotherapy trials. So as I mentioned, pembrolizumab and trastuzumab and chemotherapy is already approved in HER2 positive disease. This was in May of 2021. And 2 weeks earlier, in April of 2021, we got nivolumab plus chemotherapy approved in the United States in first-line treatment, irrespective of PD-L1, and it's for typically HER2 negative patients. And it's important to note that in the US, we no longer have immunotherapy in the second or third line because the pembrolizumab approval was reversed. So if your patients were to get immunotherapy, it's really just in first line for adenocarcinoma. While nivolumab is still approved in Asia, irrespective of PD-L1, in third line, and more of patients in Japan and Korea, for example, get third line therapy. So strategically, that's still an option. There's, of course, pembrolizumab approval for MSI high and TMB high patients in later lines, but we don't wait that long. We give them the drugs in the first line, usually. So what about PD-L1 testing? A lot of controversy about this topic. It's not the perfect biomarker. It's the only one right now we have. Obviously, MMR efficiency trumps everything, right? It's the best biomarker. It doesn't always co-occur with PD-L1, so you have to test religiously for both, because we do have PD-L1 negative or low tumors that are MMR deficient. And, when we talk about PD-L1, this positive example, with the brown staining that's on the right is not always this clear. Usually it's a tiny fragment of the cells, depending on the small size of the biopsy and so forth. And the pathologist has to calculate the staining in the tumor cells, lymphocytes, macrophages, any sort of stromal component in the actual biopsy. And if it's an acellular, low cellularity sample, you can imagine how there's a confounding variable, but the pathologist actually has to count the positive cells and divide it by total number of viable cells. So there's a lot of variability, and that's why I don't feel comfortable when clinicians get and because of NCCN guidelines, there is this level 1 listing for CPS 5 or greater or equal to, but really the difference between CPS 4, CPS 3, and CPS 5, you can imagine, is relatively arbitrary. So that's some topic that we can discuss about when to use immunotherapy in first line setting. I think CPS 5 or greater is a really, nice cutoff, but there's also some gray areas beyond that. I think once we have something else to use in the first line setting with zolbetuximab data coming out, that question may be not as urgent of a question to discuss. These are the data that led to CheckMate 649 approval in first-line setting. The FOLFOX Nivo versus FOLFOX data was just recently updated at ASCO GI, the 3-year long-term follow-up. What's unique about this study is the first study, registration study, to use oxalic as a backbone. It's the first study that included esophageal together with G-junction and gastric adenocarcinoma. And also the first study to openly use FOLFOX, because that's what we like in the clinic. It really lends itself well. So it's important to consider those options. So these are the survival curves. What's great to see is the sustained separation on the curve, right? When we look at the survival curves, things we care about are the early and the sustained separation. And actually in CPS 5 or greater and in all randomized intent to treat population, you see that. And the other milestone that we reached is for the first time, we saw a trial that crossed a 1-year survival, right? In a global study where a lot of patients were accrued in China, US, Europe, where patients tend to do worse than Japan and Korea. So the median OS of 13.7 months is really the benchmark now to beat for all comers. And again, there's long-term survivors. For MSI population, the benefit is even more robust. That's why it's critical to test for MSI. Hazard ratio is 0.34. And in terms of the response, right, a lot of pros and cons come into use in first-line setting. You'll see some of the zolbetuximab data. There's no benefit in overall response rate. Here we have benefit, although, in PD-L1 negative patients, the difference is not as pronounced. But for PD-L1 positive, the delta is 15%. For all comers, it's 12%. And if you do respond, the duration of response is more pronounced. And patients who we have data to show that patients who respond, their median OS and progression-free survival is even more robust. Its median OS was 27 months in patients who are responders. So it's critical. Response in first-line setting is important because patients are symptomatic and they need disease relief. So when you're considering first-line options, those are the things I usually think about. So what about the third arm of CheckMate 649, the Nivo-Ipi arm? Was not a win. Unfortunately, there's no chemotherapy-free treatments in our disease. We need chemotherapy, and there is an increase in survival eventually with longer long-term survivors, but not good for the first 12 months. There's a detriment. So we're actually presenting the biomarker data at ACR, so hopefully you guys can tune in. It's quite interesting. So I have a case of an MSI patient we left in. We can talk about. It's important to consider. This is a woman who came in with early stage disease while she was getting therapy with a cross regimen, which no one should give for adenocarcinoma. And we can talk about. I can come back to talk about it another day. But she got carbotaxol radiation and was progressing. Then got FOLFOX, still progressing. Her disease was growing in front of our eyes. So we put her on immunotherapy at CheckMate 32, which was a study that was open. This was in 2014, and she had a great response. In retrospect, she had an MSI tumor. And this is her response. She had a complete response with nivolumab, actually perforated her tumor. And this, I put in this as a slide deck, always to remind yourself to test for MMR deficiency in perioperative setting. These patients should not be getting chemotherapy. You either take them straight to surgery or put them on an immunotherapy trial. And the biomarker overlap, we'll talk a little bit about, but essentially, as claudin inhibitors are coming onto the market, we now have data from Spotlight and the GLOW study showing that only about 15 to 20% of patients overlap with CPS 5 or greater. Retrospective data suggests that maybe the overlap rate is higher. I think prospectively, we need to test more tumors, and I suspect it's a lower risk overlap, so that's okay. So these are the data for the first-line zolbetuximab studies. So there were 2 studies. You can tune in. We just did an ASCO plenary discussion, so you can tune into those discussions online. Essentially, zolbetuximab is a naked antibody that binds claudin. And again, as I mentioned, we look at early separation and sustained separation. Spotlight had a 36 months follow-up rate in some patients, although many are still censored. It looks like there is a sustained separation, but the separation happens later on. We talked about the median OS, right, of 14 months, which was great. Here, 15 months in the placebo arm. This is because it was mostly a Korea and Japan study in the US and other countries as well, but heavily accrued in Japan. So it's, it drives the survival benefit, but the hazard ratio is 0.75, which is nice. Overall response rate, unfortunately, was not improved, which again, it's a disease stabilizing, not necessarily disease shrinking regimen. It's a naked antibody and there's no single agent activity, but it helps chemo work better. These are some of the claudin strategies that are on the market. They're better, more selective inhibitors with TST-001. It's also a negative naked antibody, but preclinically it seems to work even in claudin low expressors. The way we describe claudin positivity is IHC 2+ or 3+ in 75% of the tumor sample or more. And of course, there's the armored there's CAR T cell therapy, there's bispecific antibodies, ADCs. So the claudin, drug development field will be something to watch out for the next year or two. The next sort of target to explore is the FGFR2b overexpression. The FIGHT study, the bemarituzumab phase 2 was published in Lancet Onc. You should check it out. Very promising data. If these median survival and the deltas pan out with a hazard ratio of 0.4 in a phase 3 study, this will definitely be practice changing, and those studies are ongoing. So lastly, we'll just give you a refresh on second line therapy. Taxol RAM is still the king in second line. TDXT is good for HER2 positive. And then beyond that, I would say, please consider clinical trials. There are some, irinotecan-based options. FOLFIRI ramucirumab is also now a part of NCCN guidelines. TAS-102 is an option. And now regorafenib, which is another multi-tyrosine kinase inhibitor that's entering the market through some of the recent data. So the outlook for the future is, bright. Gastric cancer is always evolving. The next wave of data will be in the perioperative setting, so you should watch out for that. A lot of the data is coming out from the Keynote studies and the Matterhorn studies in perioperative. And as I mentioned, the bemarituzumab data and also dual anti-PD-1 VEGFR2 inhibition. This is the regorafenib data that came out recently against placebo, again, validating the disease stabilization approach in later lines of therapy, which is great. So thank you for your attention. Please routinely test your patients for HER2, MMR, and PD-L1, and soon Claudin 18.2 once it becomes FDA approved. Zolbetuximab is likely the next FDA approval in this disease, hopefully in the next 6 months or so. And so then we'll have to figure out the way to strategize and offer the patients maximum therapy. This is how I think about it in first line setting. Clearly MSI high, PD-L1, and HER2 are the first 3 biomarkers to target, and then Claudin 18.2 is the next one. The next generation inhibitors for Claudin 18.2 are likely to be, very promising. We just need to see more data. Thank you for your attention.